Welcome to yet another remote cardiovascular medicine grand rounds. Today is my distinct pleasure and honor to introduce Dr. Bobby Yeh from Beth Israel Deaconess. Dr. Yeh received his undergraduate degree from Stanford University, subsequently earned a master's in health policy from the University of London, an MBA from Oxford University, and then an MD degree from the Harvard Medical School. Dr. Yeh did internal medicine residency at MGH, followed by general cardiology training at UCSF, and then he subsequently returned to Boston, where he received his interventional cardiology training at the MGH. Dr. Yeh initially took a faculty position at the MGH, where he remained until 2015, at which point he was recruited to the Beth Israel Deaconess Hospital. While at MGH, I had the pleasure of overlapping a little bit with Dr. Yeh and can attest to the fact that he was just a tremendous clinician, researcher, mentor, and educator. And although he certainly had some people that he formally mentored extensively, he always was more than happy to lend his time for informal mentoring. And he actually mentored my senior resident talk, which you may or may not remember, and has been so kind as to be a bouncing board for questions of mine over the last better part of the decade. As I mentioned, in 2015, Dr. Yeh was recruited to the Beth Israel Deaconess Medical Center, where he wears several hats right now. He is an associate chief of interventional cardiology. He directs the complex coronary intervention program, where he clinically specializes in CathPCI. He is the director of the Richard A. and Susan F. Smith Center for Outcomes Research in Cardiology at the Beth Israel Deaconess Medical Center. He's an associate professor at Harvard. He holds the Katz Silver Family Endowed Chair in Cardiovascular Outcomes Research. He is a principal investigator at the Bayham Institute. He is very widely published. He has mentored countless successful junior and now not so junior faculty members. He is an expert in evaluating cardiovascular devices and therapies, both in clinical trials and observational studies. He has been involved in several numerous high-profile studies and trials, including the DAP study. And he particular interest is on the emphasis of understanding methods to improve the value of novel technologies as they're used in clinical practice. And beyond that, he's just a wonderful human being, an engaging speaker, and a true triple threat. And so it is my absolute pleasure to introduce Dr. Yeh, and I very much look forward to hearing him speak today. So thank you for joining us.
Thanks so much, Dan, for that overly generous introduction. And it's really an incredible pleasure for me to be able to speak to you. I wish I could do it in person with everything going on. So many good friends at Yale. And just before I start, I did want to specifically say that there are just some people who've been tremendous in my career who are in the audience today. Especially Harlan Krumholtz, who I really consider the father of this field of cardiovascular outcomes research, as well as a whole number of collaborators, Jeff Curtis, and then people that I see who are doing tremendously well that I've had the opportunity to work with while they were mentees, including when they were trainees, including Nihar Desai, Rohan Kara, Kamal Faridi, one of ours, Oyeri, I see in the audience as well. So really a tremendous pleasure for me. But without further ado, I'm going to be speaking really on a topic that I think is germane to a lot of what we do in cardiovascular care, as well as cardiovascular research. These are my disclosures, and I think the relevant disclosures here are, I'm going to speak a little bit on the SAFE PAD study, which is a jointly sponsored study by 5 industry sponsors, and I do serve on the Circulatory Systems Device Advisory Panel for the US FDA. And I want to start with this question of how do we know what we know? Obviously a huge, important question. And really, if you think about what the idealized state of how we know what we know is, it probably would begin, I think, something like this, that we have scientific theory, and that's really, what we consider biologically plausible. And we create hypotheses based on these. And then we test these hypotheses in preclinical evidence, and then ultimately in ideally randomized clinical trials. And then later on, we then take that evidence that we've learned in clinical trials and we integrate that into practice. And then through observation of whether or not this is applicable to those settings, we developed evidence-based practice, which can feed back into biological plausibility and new theory. And then this virtuous circle would continue. In reality, however, and really this is the underlying thesis of my talk today, is that there exists an incredible conflict between the generation of scientific evidence and how we practice clinically day to day. And in particular, I think the way first that we generate evidence, particularly in trials, is really not conducive to how we integrate that evidence into clinical care. And the second is that there are barriers to the development of evidence. Specifically, we often move from scientific theory directly into practice and observation through the development of an art of medicine that's not necessarily grounded in scientific evidence. And over time, we develop standards of care which are not necessarily supported by scientific evidence. They certainly haven't arrived at those, we haven't arrived at standards of care through the generation of evidence, but instead through the practice of medicine. And that practice of medicine actually then creates barriers to the development of evidence and an evidence-based practice. And I'm going to try to illustrate these concepts in 3 stories. And the 3 stories are titled, and I think they'll become self-evident as I talk about them: Not Your Average Joe, The Real World, and Free Falling. So we'll start with Not Your Average Joe. So this is an artist's depiction of the mythical creatures of Scylla and Charybdis, which were, by legend, located in the Straits of Messina between Sicily and Calabria. And it was Odysseus who sailed through these dangerous rock cliffs on one side, which is sort of stylized as this dragon. On the other side, these whirlpools, which was Charybdis. And we, of course, as cardiologists, navigate this narrow therapeutic window between 2 evils commonly, particularly in acute coronary syndromes or in the cardiac cath lab. And those are bleeding and thrombosis. And we are seeing actually the electrophysiologists as well with atrial fibrillation management. This is often, I think, the most common sort of narrow therapeutic window where we are trying to guide between. And in the evidence generation for how we are supposed to navigate this, you will often see trials such as these. So this is the result from the Triton trial, which was a comparison of prasugrel versus clopidogrel for patients presenting with acute coronary syndromes. And the primary results of the trial presented in the New England Journal, that prasugrel, the more potent P2Y12 inhibitor, led to a significant reduction in the ischemic endpoints of cardiovascular death, MI, or stroke. But on the other hand, there was a 50% increase in life-threatening bleeding. So we had a similar type of result with the DAPT study that Dan had mentioned earlier. So the DAPT study was a study of 30 months versus 12 months of dual antiplatelet therapy after routine, as well as acute PCI. And we found a significant decrease in stent thrombosis, myocardial infarction, death, MI, or stroke. But this was counterbalanced by an increase in gusto moderate to severe bleeding. And I think anybody who reads the literature in this area, whether it is acute coronary syndrome management, dual antiplatelet therapy, systemic anticoagulation, this is often, some version of this finding is often the top line finding for these more potent versus less potent antithrombotic strategy papers. And the result of the DAPT study, which was, it was a $100 million study that was conducted, published in 2014. And in the ensuing 2 years after that, there were a number of scientific debates about how we should interpret these results along with other trial results. And so these were some of the presentations at scientific meetings that I was invited to participate in during that 2-year period. Debate: should current USA and European DAPT guidelines be changed? On one side, yes, longer is better. That was always the argument that I was given. Con, no, current guidelines are best. Another debate, this was probably at the American Heart Association meeting: should long-term dual antiplatelet therapy be used after MI? Yes, the data are strong for clopidogrel and prasugrel, a DAPT trial that was assigned to me. The con: slow down, excess bleeding, no mortality benefit, do no harm and save money. And finally, there was a signal of an increased mortality with dual antiplatelet therapy. And then we debated whether or not the mortality issue was real. Yes, the increased mortality is a serious concern. No, mortality risk is exaggerated. In fact, there may be a survival advantage. And the common denominator of all these debates was, one, that they all had to have an exclamation point in their titles, and two, it was really, an incredibly split debate, that it was either all for or all against, and really it was this debate that long dapt is best versus short dapt is best, but that was the wrong debate. The right debate, as every clinician knows who sees patients, would say that, well, sometimes long dapt is better and sometimes shorter duration dapt is better. And the reason we take as much time as we do reviewing the medical record or talking to patients about what their preferences are is that we are trying to find out what the best treatment strategy is for that individual patient, that there is no one size fits all. And this challenge is that even though clinicians implicitly recognize that there's no one size fits all in the way that they treat patients, the clinical trial literature does not really do a good job of recognizing this. This is a typical, let's say this is a representative population, heterogeneous populations that might enroll in a clinical trial. And then this figure is really derived from ideas of John Spertus, who's really been a mentor of mine as well. But let's say that green patients are those expected to derive benefit from treatment, blue patients expected to have really equivocal response, and red patients expected to be harmed by perhaps extended duration dual antiplatelet therapy. Well, the average treatment effect of our study and most trials gives you this response for this average patient who really doesn't exist. And what you really want to know is what is try to be able to identify and separate the red patients from the green patients and the blue patients, such that you could identify those patients who should receive longer duration dual antiplatelet therapy, those that perhaps the choice was equivocal and it would be a patient preference decision, and those for whom there would be clear evidence of harm. So this is the typical way that heterogeneous treatment effects, this is what we're looking for. Heterogeneous treatment effects are different treatment effects for different patients, different types of patients. But in randomized clinical trials, usually it's identified using these forest plots. And this is always, either figure 3 in a randomized clinical trial, where you see for men versus women, the response is usually the same for patients who are high BMI versus a low BMI, for those with chronic kidney disease versus those without. And the problem with this type of subgroup analysis is that it is dramatically underpowered. It considers heterogeneity really only on the relative scale. These interaction terms are comparing hazard ratios, which are estimates of relative treatment effect, as opposed to absolute treatment effect. And it only considers one variable at a time. So in this case, age, and then race, and then sex. And it rarely finds meaningful variation. There's really a small number of these interaction terms which find that you should treat one patient group differently than another. But in clinical practice, we treat on the basis of number needed to treat, or absolute risk reductions, more so than we do on relative treatment effects. It matters that the absolute treatment effect is 5% and not just the relative treatment effect. And we integrate the constellation of patient characteristics at a single time. We don't just look at whether or not the patient in front of us is a man versus a woman and then move on to the next variable. We look at this patient and say, this is a 75-year-old woman with a BMI of 23 and chronic kidney disease. So we try to integrate that constellation of patient symptoms. And so personalizing care assumes a high degree of meaningful variation, whereas typical clinical trial analyses rarely find meaningful variation. That creates a barrier to how we can integrate clinical trial information and results into our practice. So one way around this is, and these are ideas that have really been pioneered by David Kent, who's at Tufts. He's been making these arguments for a long time, that we really should be reporting heterogeneity in treatment effects in clinical trials based on a different method. And we should be considering heterogeneous effects on both the relative and absolute scales. And we should be defining these patient populations based on multivariable prediction models. So integrating multiple patient characteristics at one time to identify high risk versus low risk groups. So we tried to apply these concepts to the DAPT study. Can we identify patients predicted to have a large reduction in ischemic events from longer duration. So a big benefit with longer duration DAPT with only a small increase in bleeding. Can we separately identify other patients predicted to have a minimal reduction in ischemic events from longer duration of DAPT, but a large increase in bleeding? So those patients who are more likely to be harmed. This presented additional challenges because we knew that bleeding and ischemia were highly correlated endpoints. Things like age often predict both ischemia and bleeding. Diabetes might predict both. But the truth of the matter was that even though there are elements, common shared elements that predict both, our exploration of literature was that nobody had really tried to model these outcomes separately in a way to separate the bleeders from the thrombosers. So that's what we tried to do in the creation of what ultimately we called the DAPT study. And the way we did that is we developed prediction models to predict the ischemic or the risk reduction in ischemic events or the beneficial effect of DAPT. We developed separate models to predict the harmful effect of DAPT. And then on an individual patient benefit, we tried to identify those factors that predicted a greater, a more positive or more negative net treatment effect. From this, we were able to create this rather simple score, the DAPT score, and what the score did within the trial. So this is internally fit data to the trial. But what it did within the trial is identify those patients who, as you went up in the score, they had a greater reduction in stent thrombosis. If you go from quarter Q1 to Q4 of the score, greater reduction in stent thrombosis, greater reduction in myocardial infarction, and actually a lesser impact on bleeding. Almost seems too good to be true. But in fact, even in external samples, so this has now been validated in more than 100,000 patients externally, actually not even by us, by other groups internationally, that the DAPT score consistently identified individuals who had both an elevated risk of MI or stent thrombosis and a lower risk of bleeding. So those patients who would really benefit the most from dual antiplatelet therapy, those with high scores, had both an increase in MI risk and lower risk of bleeding. So we managed to uncouple those risks of ischemia and bleeding. And in the small number of randomized clinical trials that have looked at this, that it's pretty clear that those patients with greater scores had a significant decrease in net adverse cardiovascular events. So that's the combination of ischemic and bleeding events when they were given higher versus lower intensity DAPT. And those patients with low scores seemed to be harmed by it with a significant interaction. So we felt strongly that this multivariable approach and taking it, really borrowing the ideas from David Kent, John Spurtis, and others, and applying it to a randomized clinical trial really did create a score which could help take a clinical trial, a big clinical trial, an important clinical trial, but help it apply to individual patients more strongly. So the net takeaways: primary clinical results apply to average patients, but the art of medicine rarely assumes that any patient is average. Traditional trial subgroup analyses were insensitive for identification of treatment effect heterogeneity that is important for guiding clinical care. And this is a particularly important issue when treatments have the potential for both benefit and harm. Finally, I think it showed that prediction model-based approaches can separate patients expected to have the most benefit and the greatest harm in a manner that informs clinical decision-making. And I'm glad to say that this model has been applied to other randomized clinical trials as well, and there are other proposals to do so in spaces outside of cardiovascular medicine. So I'll move on to my second story. And if you are born probably in the 1970s, you probably recognize these 7 individuals. And if you're born later, you're thinking that they're terribly out of style. These are the participants in the first season of MTV's The Real World. And if you've seen The Real World, you know that the concept is to take a mishmash of individuals, bring them together, and see how things turn out. And often they don't turn out so well, which is a good analogy for, I think, how we analyze real-world evidence, which is often to take a mishmash of high and moderate and sometimes low-quality data, mix it with an assortment of different methods, and sometimes the results come out okay. Sometimes the results come out and make no clinical sense. But the reality is that real-world evidence has become an increasingly important thing for us to better understand, particularly as legislated in the 21st Century Cures Act, which actually explicitly asks the FDA to better incorporate real-world evidence into regulatory decision-making. And so how should real-world evidence best be used to support medical, therapeutic, and device evaluation? And so on one side of the ledger, we have careful scientific experiments which haven't used real-world data, and those were studies like, for example, the Triton trial that I mentioned, traditional randomized clinical trials. And the critique here is that they're hard to do, expensive, often not feasible. They enroll very carefully selected populations that may not be generalizable. And on the far end of the other side, we have real-world evidence, which has usually been thought of as traditional observational comparisons using some sort of regression or propensity score-based approach. And these can be very challenging to conduct. So I'll give an example of the Impella mechanical circulatory support device used for PCI, which has grown exceptionally in terms of its use in the United States. And many would argue, I think most would argue, without strong, substantial evidence to support its use. And in a typical, I think, analysis using real-world data, Aminamine and others looked at this in the premier data set, which is a hospital administrative claims type of data set, and looked at Impella use versus balloon pump use and an assortment of indications, and published that this was associated with a higher risk of death, bleeding, acute kidney injury, and stroke. And this is an exceptionally challenging, I think, question to be asked, particularly with an administrative claims data set. I'm being self-critical. I participated with these authors at various points on the study. And the challenge really has to do with the fact that we don't choose to use treatments, therapies, and devices, and in particular this device, randomly. And the analogy I use, and we've had some discussions about this recently, Rohan, Karen, and I were sort of chatting, we use this term association of Impella versus IAPP use with clinical outcomes, but of course, really what the implication of this, the intent of this is really to try to understand this causally. And I think we shouldn't fool ourselves that that's really our goal when we do these studies, is try to understand the causal impact of Impella versus IAPP use. And the real difficulty for the device like this, I think, is best illustrated by this analogy, which is if you are fans of New England football, then you know that this still image is a clip of Doug Flutie's, I think, one of his most famous football plays of all time, which is his heroic Hail Mary pass at the end of the game to beat University of Miami. And the Hail Mary pass, if you think about it, is the pass you throw at the end of a football game. But in a purely observational sense, throwing an Hail Mary pass at the end of a football game is strongly associated with losing the game. But the conclusion, of course, is not to stop throwing the Hail Mary pass at the end of the games. And one might look at a bunch of data if you really were naive to understanding football at all, and you would say, boy, the team that takes a knee at the end of a football game seems to always win. So why don't we just take a knee at the end of this game instead of throwing this Hail Mary pass? Of course, that makes no sense. And also, it could very well be that there might be other plays that are better than the Hail Mary pass on the last play of the game. But just a pure data analysis to look at it would have a hard time trying to discern it. And I think when I think about my own use of something like the Impella circulatory support device or other devices that we are using really in this sort of bailout circumstance, it's really hard to answer it, particularly when the data may not have the granular information as like a clinical registry or a clinical trial might have. So some of these less granular data like administrative claims. So we think about, is there a better way to use real world data to help us corroborate some of these findings? And I want to talk about two ways that that our group, and I know yours and Jeff Curtis thinks about this a lot. We collaborate with him on some of these questions. But the two are quasi-experimental studies and pragmatic clinical trial designs. And all of these would qualify under the FDA rubric of what constitutes real-world evidence. So quasi-experimental designs rely on finding randomization in nature. So they're commonly used in the social sciences, but they have been very slow to migrate into the medical therapeutic evaluation space. Increasingly so, however, I'm pleased to say. But sources of random variation might be things like physician preference. So maybe Dr. Curtis uses bivalirudin for his PCI, Dr. Pinto uses heparin, And some of these choices have to do with our training and our exposure and our random choices that physicians make. And if you amalgamate these sort of physician random preferences over an entire, country's worth of cardiologists, maybe you have something that has enough randomness that you can compare bivalirudin versus heparin using this sort of instrumental, what would be called an instrumental variable approach. Another approach is the rapid adoption or de-adoption. So drug-eluting stents, for example, were 0% used in 2002. They didn't exist. And then 2003, they were basically 90% of all stents that were in circulation. Then 2007, there was a scare. They were down to 55%. And these vast and sort of rapid swings in the adoption or de-adoption, when other clinical characteristics of the patients might not be changing as much in that short period of time, can be leveraged and can be exploited to find treatment effects that may be more causal than doing traditional observational comparisons. Formulary coverage is another source of randomness that may be exploited. For example, if Yale New Haven stocks drug A, Johns Hopkins stocks drug B, those decisions are really financial and that aren't driven by clinical decisions, then those could be exploited as well. So I'll give you an example of one that we tried to connect. So vascular closure devices. So these are the devices that are used in femoral access procedures for things like large bore access or for PCI. And if you think about the femoral access, those of you who rotate through the cardiac cath lab, when you do a bad stick or there's a lot of calcium in the artery, you tend not to put and this is when we did more femoral access than we do now, you tend not to put a closure device in there. So there were some things that might make you concerned that there would be confounding by indication, that those wouldn't be random decisions about using access devices. But this was a large analysis out of the UK that looked at 270,000 plus patients receiving access devices versus not. And they found, using this propensity score corrected approach, that there was a 9% mortality reduction associated with the use of vascular closure devices compared with manual compression. I would say that this type of expecting there to be a mortality benefit with a closure device when the procedure itself, PCI, is not necessarily itself known to be associated with any difference in mortality, would be really a stretch. We looked at this same question using an instrumental variable approach, because it turns out that some operators use vascular closure devices 100% of the time and others don't use it at all, and there's sort of everything in the middle. And when we did it using an instrumental variable approach, using this what we thought were random physician preferences, we saw that it had no association with mortality and really actually a negligible association with reduced bleeding. And so the really interesting thing about this is that these two papers, which say entirely different things, were published literally in the same journal 1 month apart from each other. And so this is, I think, the confusion of real world evidence and the need to develop some standards. So who's right? It could be that really areas of mortality reduction and maybe our analysis was wrong. And so there can be the use of these tiebreakers. And I think it requires thinking about observational studies in an experimental sort of manner. So if you remember from, the last time I did like one of these gel electrophoresis, probably was in college lab space. But when you did these gel electrophoreses, you would always have wells that were control wells. And in one of the wells, you would not put any, whether it was DNA or whatever type of blot you were using, but there would be nothing in the well. And when you ran it, if a band showed up in the well that you put nothing in, then you knew that the entire gel was contaminated. And we have these equivalent types of things that can be done in observational studies. We refer to them as falsification endpoints. And they're really endpoints that we don't think can be plausibly affected by the treatment strategy. So my favorite example to use is, when we use things like radial versus femoral access, or when we use things like vascular access closure devices, well, these things shouldn't affect gastrointestinal bleeding. They might affect other types of bleeding, namely related to access site, but if they affect gastrointestinal bleeding, then something is probably wrong in your study. And when we did our analysis, if we use a propensity score analysis to compare access closure devices, we can show, we think falsely, that access closure devices reduce GI bleeding, but using the IV approach, there's really no difference in GI bleeding at all. So this can be something that I think can be incorporated more routinely. I think it is starting to be done more routinely by certain groups like Yale's, ours, and others, Duke's. But I don't think it has become the standard to do such sort of thing, and it takes some creativity to think about it. We've tried to take all these concepts and integrate them into what we're calling the SAFE PAD study. And this is a study we're doing in partnership, have designed this in partnership with the FDA to evaluate the signal of harm associated with paclitaxel-eluting devices used for peripheral vascular disease. And here what we've done is we have an inverse probability treatment rate approach, but also a sensitivity analysis using the instrumental variable approach. There are other sensitivity analyses looking for missing confounder data. The analysis is pre-specified and registered in clinicaltrial.gov. And we think that this includes falsification endpoints, et cetera. We think that this sort of more rigorous experimental approach, the same way that we think about randomized clinical trial design, can be applied to observational data more routinely for real-world evidence to effectively become strong enough to be used for regulatory decision-making. True randomization, of course, is still optimal, and it's really hard to find these quasi-experimental approaches for every question. Requires a lot of assumptions. Good instruments are very difficult to identify. So I want to talk a little bit about pragmatic clinical trial design, specifically with regard to whether or not we can use routinely collected data in place of clinical trial adjudicated data. And so one, the country that's done this best has been Sweden with the Sweetheart Registry, and an example of this is a study called the TASTE trial of thrombus aspiration during STS segment elevation MI. And in Sweden, essentially, they have the entire country is covered by a registry that can be used to capture clinical trial outcomes during routine clinical care. And so they've leveraged this to perform a large number of very pragmatic randomized clinical trials that have been very efficient and comprehensive. And so we've looked at some possibility of doing this in the United States. This is a collaboration closely with the American College of Cardiology, including JEPFA is involved in this. It's called the Extend trial. And so we merged a couple large clinical trial programs, the DAP study, the core valve pivotal studies, the ACC NCDR registries, as well as administrative claims data from Medicare. And our questions were, how do outcomes determined by CEC adjudication compare to those outcomes assessed through passively collected data? And how do the treatment effects compare for these trials? So here we'd have trials that we could evaluate using how we evaluated those outcomes in the trial itself using clinical trial adjudication. And then because we've linked all the individual patients, we can also assess how the trial would have looked had we not adjudicated those outcomes and just used claims instead. Jordy Strom, one of our junior faculty, led this analysis here, looking at the primary endpoints of the US core valve high-risk trial. And this was the published trial results. The principal primary outcome was mortality, and the top line result was a non-inferior outcome. And not surprisingly, had they not actually used clinical trial adjudication, because all-cause mortality is not something that requires probably substantial adjudication, that if you use the administrative claims data, you find essentially the exact same result. And actually, where the results differ, it's likely that the claims data were in fact better at identifying the precise states of death than site monitoring was. Even a slightly more complex primary endpoint, death and stroke. This is results from the intermediate risk trial, Circulatory trial, and the trial result on the left is what they reported. And here, if we take the same trial and use use Medicare claims to find the outcomes instead, we find effectively the same results. So here again, the top line results of the trial would be identical had they not used clinical trial adjudication, but instead used administrative claims. This is the results of the DAP study. This study was led by your own Kamal Faridi. And Kamal in this study looked at the DAP study, the primary endpoints of major adverse cerebrovascular and cardiovascular events. This is death, MI, and stroke. Includes stent thrombosis of 30 months of therapy versus 12 months of therapy with DAPT. And again, on the left, the clinical trial adjudicator result. On the right, the result with Medicare claims. And really the same result could have been achieved here for the primary endpoint. So it's not all perfect, however. There are some endpoints which do require some adjudication, or at least the definitions are more subjective. And this is the case with bleeding, which is an important endpoint for the DAPT study. And in the DAPT study for 30 versus 12 months of dual antiplatelet therapy, you can see that when we looked at bleeding claims, they were much higher rates of bleeding claims than there were adjudicated bleeds that met the Gusto criteria in the DAPT study. But overall, the hazard ratio or the relative treatment effects were similar. So there's really variable concordance of these endpoints, depending on which endpoints that you use. Death, as I mentioned, was 100% concordant, and the MACE endpoint in MI, which had high concordance as well. But as you get down to the stroke endpoint and the bleeding endpoint, there becomes less and less concordance. So I think one of the takeaways there is that it really depends on the trial populations. I should also mention that the DAPT study could only link a smaller fraction of individuals because this was Medicare claims. The DAPT study included patients who were less than 65 years of age. And as a result of that, it couldn't link everybody, whereas the TAVR studies could link the vast majority of patients. The takeaway from the real world segment is that physicians don't choose treatments randomly. And the intentional choices of good physicians can make real world comparisons using traditional methods problematic. But fighting natural experiments can overcome some, but not all of these limitations. But they're really seldomly used in the literature right now. I think they're going to be used more and more. And finally, preserving randomization, but following patient outcomes using passively collected data may be a suitable middle ground that lowers trial costs, but it has different risks depending on the treatment population and the endpoints. So we have some ongoing conversations right now with US FDA about the fidelity of this approach. And I think what they're most comfortable with early on is to support indication expansion. For example, TAVR for bicuspid aortic valve disease, where you have an elderly population, and the types of endpoints like death and stroke and procedural endpoints, aortic valve replacement, would be suitable in an administrative claims population. So the final part of my talk is titled Free Falling. And so people who are accustomed to looking at angiograms can look at this, and I think immediately they might wince up, and it makes them nervous because you can see here there's a critical left main lesion for this patient. And often when there is a resident or medical student rotating through us, we'll all sort of tense up and say, oh, that patient definitely needs treatment, and we might call the surgeons, or depending on whether or not the patient is a surgical candidate, maybe this patient will undergo a high-risk PCI. But for the most part, we think that this patient has to be treated. And the medical student will ask, well, how do you know? And often you don't really have a great answer for that question. But one of the things that's often heard on rounds that you hear people say is, well, we don't, even though we don't have evidence, we know, just sort of like the way that we know that parachutes might prevent you from dying if you jumped out of an airplane. And we don't need parachutes, RCTs to tell us that parachutes work. And this is actually Leonardo da Vinci's drawing of one of his first ideas for a parachute. And I would argue that design really would need an RCT to tell us that it would work. But of course, since then, parachutes have been improved iteratively over time. And now I think we confidently believe that they don't work. But, and actually, proponents of using this analogy often cite this very humorous article in the BMJ in 2003. Parachute used to prevent death and major trauma related to gravitational challenge, systematic review of randomized controlled trials. And in this paper, which was this meta-analysis in the Christmas edition of BMJ, they wrote, as with many interventions intended to prevent ill health, the effectiveness of the parachutes has not been subjected to rigorous evaluation by using randomized controlled trials. And ultimately, they say that we think that everyone might benefit if the most radical protagonists of evidence-based medicine organized and participated in a double-blind randomized placebo-controlled crossover trial of the parachute. And of course, they were criticizing our sort of reliance on RCTs to know what things work. But the thing about this is I actually think that Smith and Pell had it wrong. And I think actually this idea that that it's okay to not test therapies is really pervasive. And these beliefs that incompletely tested treatments are effective are pervasive, and they're very harmful. They're very harmful for our ability to actually develop evidence. And clinical trials, there are people who do propose clinical trials to test these treatments against a strong sort of tide of lack of clinical equipoise, and that itself can create problems to how we interpret the literature. So how do we as physicians, and I think this goes back to the underlying thesis of this talk, which was, when physicians day to day are asked to make decisions for their patients in the best interest of their patients, how do we then take a step back? We spend most of our time trying to exactly not develop equipoise, right? We're trying to figure out which treatments are the best ones for our patients, not which ones which patients have equipoise for two different treatments. And so how do physicians as agents for their patients decide who can and can't enroll in a trial? And how might these decisions impact trial results? So, we did this sort of tongue-in-cheek randomized clinical trial working closely with a good friend, Brahmaji Nalamothu. And we actually, when we were up in planes visiting our family or taking vacations, we actually tried to consent the people sitting next to us for a randomized clinical trial. And we told them would you jump out of the airplane right now if I flipped a coin and you had a 50-50 chance of jumping out with or without a parachute? We told them the primary endpoint of this trial was death or major traumatic injury as assessed by the Trauma Injury Severity Scale, which is a real validated trauma scale, within 5 minutes of impact of the ground. And usually they were very confused by it. Some of them thought it was sort of funny, but nobody said they would do this trial, except for 23 individuals who then bravely jumped off of airplanes. And when they jumped out of airplanes, they jumped out of airplanes like this. So this was our research group. We were jumping out of airplanes. We actually randomized ourselves to the backpack with or without a parachute and jumped out of a plane that was sitting on the ground. And of course, we found no impact on death or major traumatic injury in the parachute group or the control group. And this was, of course, to illustrate this problem. And this is the problem that when there is a strong background of lack of clinical equipoise, rightly or wrongly, it really makes the enrollment in clinical trial problematic. And if one does conduct that clinical trial against that background, you can be sure that the patients who might benefit the most will be the ones most likely to be held out of that trial. And so what is evidence for this problem? There are so many trials right now that there are difficulties with trial recruitment because the physicians just do not think that there is equipoise. And most of the time there is. And so that becomes a real problem with the ability to complete these trials. If you look at the disease severity in randomized clinical trials versus the real world, the disease severity in trials is often less. And that, I think, is a reflection, again, of holding out the sickest patients from trials who might benefit the most. And really, if you just ask a physician about their clinical beliefs, and many of you in the audience are physicians, I think we know that we lose equipoise quickly, particularly when we treat patients who are in desperate need with severe illness. And so one example, I think, this is a subtle one. I think the ischemia trial was a really interesting and wonderful trial, an important trial. But in every one of these trials, there is this element to it, which I think reflects this belief that there are some patients for whom there is an equipoise. And so in the ischemia trial, you would be held out if there was this judgment call. The physician deemed that there was an unacceptable level of angina despite maximal medical therapy. And now, if you hold out these patients who might benefit the most from angina reduction with an invasive strategy, then when you look at the results of the quality of life study, you have to recognize that is going to necessarily be biased potentially to the null if there's a treatment effect. And the problem isn't that, my point here is the problem isn't that I know that all treatments work. It's that these strategies that we use to treat patients in clinical care go against our ability to enroll these patients in trials. And so we then can't discern whether or not these sort of parachute phenomena are having an effect on the results of the trial. Oops. So parachutes during the COVID-19 pandemic, I think a lot of these types of concepts have come into sharp focus during the COVID-19 pandemic, where you saw rapidly the erosion of equipoise. We developed protocols for early intubation. There was protocols that included hydroxychloroquine, ivermectin, convalescent plasma, which became, everybody knew that must work. Anticoagulation is a great one that early on, I think that there were less than perfect observational studies for anticoagulation use, coupled with a strong clinical belief that this had to be used. I was in a clinical conference here at the Beth Israel where I suggested that maybe there might be harm associated with anticoagulating patients, and was told roundly by the critical care physician that actually COVID patients don't bleed and that there was no possibility that anticoagulation could cause harm. So these strong clinical beliefs were created early on during the pandemic. And we wrote a little bit about this, Dan Kramer, Drew Kazi, and I. We wrote, when patients are critically ill, the ability to maintain equipoise fades rapidly in direct proportion to illness, so that the possibility of benefiting individual patients increasingly appears to outweigh potential harms. For high-risk cases, patients or their surrogates may decline randomization and instead receive the therapy through compassionate use, and clinicians similarly may be reluctant to rely on a coin flip rather than their own judgment. This creates circular reasoning justifying the erosion of equipoise by claims that randomized trials can't be done, and soon enough, an unproven treatment that still scientifically deserves equipoise can become, by community adoption, the standard of care. And I think while the COVID-19 pandemic has really, I think, brought this into stark relief, the fact of the matter is that subtle forms of this type of thinking really do pervade how we treat medical patients in different areas. So the takeaways from this last story: standards of care are developed that render some clinical trials difficult to conduct. Clinical trials that challenge standards of care are needed, but at risk of being uninformative. And the risk will likely only be recognized by those practicing in the field, but those in the field may also be the least objective. That's a real challenge. I think that those of us who see the most number of patients, and I'll count myself in this as an interventional cardiologist, we often are probably the ones who might identify the types of things that separate, that affect a trial's generalizability or the interpretation of trials of generalizability. But we also probably have the strongest belief in what we do, that what we're doing is the right thing. Solutions will require courage on the part of clinicians, rethinking of ethics of medical practice and clinical trials, and regulatory involvement. And I think really the main goal, and we've had these discussions on a couple of recent US FDA panels actually, is the real critical reminder that we need to conduct trials before standards of care develop. Sort of how did we get ourselves here in the first place? And for COVID-19, I'm really, one thing that I've really been impressed with was that there have been, despite these standards of care, some groups that have really taken hold and done these difficult to conduct randomized clinical trials. And I know the Inspiration group, which many of the Yale investigators were involved with, is one of those really bold, courageous randomized clinical trials that needed to be done. So this is my final slide, and it's about how we started. In this idealized world, we went from scientific theory to scientific evidence to evidence-based practice, and then back again. But there were these barriers. There were barriers to how we looked at scientific evidence and developed it, and how those were really not conducive to how we treat individual patients. And I think one of the ways that we can do that, we talked about, is to produce trial evidence that better supports individual decision-making, using those ideas that David Kent, John Spertus, and others have really pioneered. So the second is that we could use better observational study designs. I think that because we are dedicated in the development of an art of medicine, it has created challenges to using traditional study designs to study whether or not devices and treatments work. So we need to use better, more experimental designs, but we need to avoid some of the problems of developing that art and standards of care by maintaining clinical humility and maintenance of equipoise when it's deserved. And that will help us go from evidence-based practice to evidence-based standards of care, as opposed to standards of care that have developed just from the development of art of medicine. And this does require ultimately our ability to move more seamlessly from scientific theory into scientific evidence. And that requires regulatory reform to conduct these trials before standards of care developed, and to make trials easier to conduct, perhaps through the development of pragmatic clinical trials, or at least the further development of pragmatic clinical trials. That's all I have for today. I want to thank all of you for listening. I'm happy to stay on and answer a few questions, and I credit a lot to our team at the Smith Center and others who have gone on to other institutions as well. Thank you.
Thank you very much, Dr. That was an absolutely terrific talk. Would be delighted if you would be willing to answer a few questions. If folks want to either raise their hand or type in questions to the chat function. We can get some questions answered that way. Maybe I'll start though, while folks are getting their questions ready. So one thing that's, seemingly competing trends in the generation of scientific evidence is one, trying to move towards less expensive real world evidence, but the other is a shift to trying to ensure that we're including patient reported outcomes and quality of life, et cetera. How should we reconcile those sometimes seemingly diametrically opposed phenomena, both of which are very important for different reasons?
Yeah, I think that assessing patient-reported outcomes and quality of life is really exceptionally important. Obviously, it's an important movement that we have. Not all of these things that we do, and in fact, the majority of the things that we do are probably related to benefiting quality of life, and we haven't had great success measuring quality of life in clinical trials, in part because of the challenges of requiring really strong blinding to make sure that it's unbiased. And so, I think that you're right that incorporating quality of life endpoints can become more expensive, especially if you're talking about devices where sham types of things are involved. But one way that I think that we can do a better job is collecting quality of life. And I know that Jeff has thought a lot about this a lot, is collecting quality of life information more commonly in the routine course of clinical care. And that may be one of the convergence points, which was right now, we don't routinely collect something like, it seems crazy, if you ask someone outside of the field, do you know, PCI relieves angina, but we don't know how our patients are doing with regard to the angina after PCI, by and large. And so, one of the ways I think in technology and mobile devices, I've always thought that, we've done a little bit of this work here. We've handed out, we've sent out surveys, quality of life surveys after PCI. We've tried to incorporate it into smart devices and mobile technologies to collect that information from patients, but it hasn't been that scalable. It's a real important challenge. But I do think that there are movements to do this, to create quality of life endpoint data at many institutions that is part of the electronic medical record, and that may be at least one step forward in helping to make the quality of life data a little bit more pragmatic in its collection. But I'm curious if there are other thoughts, people in the group. Do I know that Erica's Spots has thought about this as well? And I think that there are institutional efforts to do this. It's just, how do you do this at scale? Continues, I think, to be a major challenge.
Yeah, no, absolutely. Thank you very much. Anybody else have any questions or comments?
Bobby, this is Alexandra. That was outstanding. Thank you very much for joining us today. I wonder if you could comment on the use of the electronic medical record to conduct randomized clinical studies. We're starting to explore that option within our healthcare system, but I wonder if you have any experience with that and taking it to multiple centers. And perhaps how would you validate that? You've done some really amazing work validating claims data, and I wonder how you would approach that with the EMR.
Yeah, it's, thank you, Alexander, and it's really incredible challenges there. It's an area where I think there's been a lot of progress, a lot of promise, and less progress made. The best, my personal best experience with that has been working in the Kaiser Permanente system, where there's a common electronic medical record across the system, where the population denominators are well characterized. But even there was a tremendous amount of validation work that needed to be done. So literally, it required, going over hundreds of records from each contributing hospital and site and ambulatory center, just to make sure that, and validating against medical chart review. Alan Goh led a lot of these early studies, and Joe Selby, when he was there, they did a lot of this work that, it doesn't publish in high impact journals, but it's absolutely foundational to being able to then go on to do a study. And that's within a common electronic health record. I mean, I think in the VA, you could do similarly. So now when you're talking about using disparate electronic health records, I just try to think even, we try to do a little bit of this at the BI versus MGH versus the Brigham. And prior to the Brigham and MGH going to Epic, it was almost impossible. I mean, there was some work that was done, even just trying to reconcile the databases within an existing health system was hard, not to mention going across health systems. But I think, across health systems, if there's a common language for the electronic medical record, like for the VA or even for Epic-based systems, that seems to be a good starting point. But I do still think the hard work of validation needs to be done. I think people want to jump though and skip that step because it's such grunt work that has to be done to make it achievable. But Alexander, I'd love to hear your opinion on how you're thinking about it as well and how you're going forward.
Well, I think so. We're conducting a study in COVID within the healthcare system, but we haven't actually taken it to the next step, which is the validation aspect, and we're struggling with that, thinking of different ways of doing it. We're currently and talk about grunt work. I couldn't agree more. We're actually manually entering data simultaneously into a database so that we can compare the outcomes. It's tedious, but as you said, I mean, I think for us to be able to go forward and to really rely on these data, I think we have to do that. So, we're struggling through the process, but and hopefully we'll get there soon. But it's it's a heavy lift for sure.
Yeah. One of the things that we are trying to do is sometimes I feel like there are some efficiencies that you can gain if you can find a common data set that multiple institutions can link to. So within the Boston, structural heart programs, we're linking all of those data. Many of those patients are elderly and Medicare insured, so we're linking all those data to Medicare. And we also have all those patients' TVT data. And so there we have a common language, which is Medicare claims, and a common language, which is the TVT data, and then a disparate language across these centers, which is our electronic health record system. And then we can see if we create things, ontologies, et cetera, categorizations of variables, and we see if they map to a similar finding when we look at it in TVT, or similar results when we look at it in Medicare and TVT. Then we feel more confident that we're saying the same thing across the electronic health record. So those sort of common big registries or data sets that can link across health systems can almost serve as arbiters of what might be truth between the two centers, if that makes sense. That's one way around just the sort of more rigorous and hands-on approach that's really laborious.
Great, thank you. And I think we just have time for one final question that was put into the chat function by Sumit Shah. He said, "Thank you for the great talk. In the absence of a clear outcomes benefit, what is driving growth of the use of device-based therapies such as Impella, Watchman, et cetera? Can data beat clinical gestalt?"
Yeah, I mean, I think it's a great question. What drives it, and I'm of the mindset that what drives it is clinicians are desperate to find something that works for these patients. Shock patients, they die, and you want to do something for them. And patients who are high risk for bleeding want to be off their anticoagulation, and so it feels, I think, wrong to clinicians to not offer something that we think might help, whether or not we know it helps. So I think that sort of emotional aspect of how we treat patients, which I think is important. I mean, you might call it empathy. I mean, it's an important part of what we are as physicians, is to try to find these alternatives for patients. But it's coupled obviously with an industry push to promote those devices as well. So the challenge with observational data is that observational data right now, I don't think can beat clinical gestalt, because you just don't know which observational data are the ones that you believe. And what people say, I've been asked the question, when has observational data ever overturned your belief system, or is it only confirmatory? I think it's a great question. I think right now, observational data confirms our preconceptions, rarely does it overturn our beliefs, but we need to get to a stronger point, and that's through better study design, I think, and more faith. We need more benchmarking of observational data against RCTs to show that we're doing the right, getting the right result. And I think moving toward that direction will help observational data actually become more valid and then potentially more practice changing.
Excellent. Well, thank you very much again, Dr. A, for joining us. It was an absolutely outstanding talk. And thanks to everyone in the Greater Grand Rounds community for joining us again. Just a quick reminder, next week, unfortunately, due to a last-minute cancellation, we will not be having Grand Rounds, but we will return the following week. So thank you, everyone, including Dr. Ye, and see everyone in 2 weeks. Take care.
Thanks, everyone.
Thank you.
Thanks, Doctor.